Good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to speak today. And also, I would like to congratulate the whole team, Dr. Sudeep Gupta, Dr. Kukreja, Dr. Vikram, and Dr. Jayant for this wonderful meeting. And we know that this is a very important exercise for developing and inculcating the research methodologies, among people. I'll come back to my question, which was assigned to me. And question assigned to me was developing a research question. And what I have tried to do in talking about developing a research question, I have tried to take the journey which I have gone through, and we'll be talking about all those, what happened, how we took those decisions, what we did, and a different situation. And hopefully that may be helpful, because I thought maybe in the Indian context, that will be more important, that how and what we do here, and our success and also our failures. As I've written in my first slide, that this is because this is the questions which we have tried to develop. There are many people who has been part of it, but there are some core people who has eaten their each other's head a lot, while developing these questions. And Dr. Vanita, Dr. Vijay, Dr. Amit Dutt, Dr. Amit Joshi, and Dr. Nandini Menon. Thought, yes, this whole is all the discussion has happened between them, and apart from many other people. But these have been the people who have eaten each other's head a lot. Starting with my first slide, and I thought the first one I'll talk about when we start doing trials and start developing research project, and then we learn how not to develop a question. This was around 2004 or 5 when I had joined Tata Hospital, and Letrozole was something very important, which is very useful drug in breast cancer. And while reading, I learned that you do have a ERPR receptor positivity in lung cancer. So it did excited me that, okay, yes, you have a good drug for the same ERPR, it works in breast cancer. And I thought, if that is the case, it will be a very useful drug to develop in lung cancer. So we wrote a protocol, and with all the various reasoning, project got approval from IAC. We did have a funding assurance from some people, so we were pretty confident that we'll be able to get this through. But that time we didn't have the differentiation between these academic studies and non-academic studies. So this study had to go to DCGI. And we send all the letters to DCGI, and people who have been doing studies at that time will realize we never got any letter from them. We went with the papers, we went to the DCGI office, but we never got a letter that what happened to the project, or what were the queries they have, or is there any chance of we are getting approval. So after a few years, we realized that in whole scheme of things, the regulatory approval in this situation was the most important bottleneck, and project never started. So, but that taught us a lot, because for us, when we were starting this, we thought question was good, but we thought that we had written a decent project. This was one of the initial ones, not the best one, but it taught us that look around many things apart from the question you want to answer. In a way, it was okay, because one of my colleagues, he did the similar project in Australia, and it was a negative project, a negative study. But having said that, it taught us, while developing a question, what do you do? Subsequently, we had a colleague, Dr. Sastry, and he was our colleague who used to work in BMT at Tata Hospital, and you can see his name here. So that time we used to interact a lot, and he was someone who had a knack of reading journal like Science and Nature, and he'll keep discussing while reading that, okay, so this is something which has come up, these are something which has a potential to develop further. And we also had a knack of writing in medical hypothesis. There's one journal where you can write any hypothesis you have in mind. So he used to write a lot. And then he used to discuss a lot that what can be done. So this was one of those work which was there in science. There was animal study. He had written a hypothesis based on that project, and it looked easy for us because we say if we can do this CD26 expression, we know that we can know its importance in patient undergoing hematopoietic stem cell transplant. And as it happened, Dr. Kode was there in ACTRAC, and she said, okay, it can be done easily. So we did write the project. We did go through this project. This was the first publication out of the project. It went to a good journal, Annals. At this moment, its impact factor is 18.2. But that time we had not realized that how we are going to take it forward. That doesn't mean I'm saying that one can't do this kind of question, but for us in our group, this was something that, hey, we did a question, we did answer that question which we had thought about, but how do we take it forward if I have a question which I want that apart from science having information, patients benefiting out of it. So we couldn't develop further because there was no drug which can inhibit it. We couldn't develop it further as a biomarker because there are too many variables. You need to do far bigger studies, and these limitation we had not anticipated when we did the study. So in spite of we initially thinking, when we had the initial publication, we were very happy about it for this question and for this study. But when after publication, when things settled down and we started analyzing that what we can achieve out of it, then we realized maybe this is something we need to start thinking from the beginning. When we have, and especially when you're thinking a longer project to answer, and we want to think that those questions can be combined to get a translational work in the clinic, being a clinician. But that doesn't mean I'm saying that people can't answer a basic question which can remain in the paper and someone else can take it forward and do it. But again, this was our thought process at that time. And that led us to start, talking more and more about what can be, which we used to see a lot, that we used to discuss a lot regarding many of those are unmet need in clinic. But these kind of work helped us understanding maybe we need to see many more things which we talk about in the clinic, and again we don't have the answers for it. So what we did subsequently was that as I said, we used to eat each other's head a lot. So we used to have a discussion regarding what is there in the clinic as a problem. So this is one example which I'll provide regarding unmet need in the clinic, and also a routine care which helps developing and answering question. So in head and neck cancer, this is the oral cavity cancer, which is the one. Head and neck cancer is the commonest cancer, and out of those, oral cavity cancer is the commonest cancer in India. Almost 50% of the head and neck cancer is oral cavity cancer. And this was a big number of these kind of disease. So we have a whole lot of people with this kind of disease. We used to come to our clinic, and we used to always wonder what kind of treatment we can provide to them. So we had one choice, that don't do anything. You give some form of palliative therapy, or we started discussing, is there a possibility that some of these patients, we can have those modalities added and see that can we remove them, resect them? Because we know that in oral cavity cancer, surgery is the most important modality here if we want to have a certain proportion of patient being without disease for a longer period. Now this discussion, which we used to many times do reflexly, and that was part of in our joint clinic, that okay, give some form of systemic therapy and let us see, can we operate some of these patients? we then put some structure to it. So these group of patients, first what we did, for showing you something which happened, this was the final product. So this was because of this concept that we wanted to convert some of these patients to see that can we convert them and make them resectable, and they do become resectable, and hopefully the outcome will be better. So this was the final outcome of that. I won't say final, we are doing some more work beyond this, but one of the important one where 700 plus patients we analyzed retrospectively to see that if you give them chemotherapy, these patients who were upfront technically unresectable, and then out of those patients to see what proportion of patient becomes resectable, and if they become resectable, then is their outcome different from patients who are unresectable. So first we tried to develop this criteria, we'll talk about it later. That first effort was to work on it and see that how do we relatively objectively define these patients where we wanted to give those therapy, systemic therapy, to see that we can subsequently resect those patients. After those work on this, defining it, we kept those data to see what proportion of patients we get resected. So almost around 40% of the patients they got resected, and then we analyzed the data that if they do get resected, their outcome is far better than as compared to the patients who doesn't get resected, where the outcome is poor. So the median survival of around 8 months versus around 20 months in this group of patients. And this was based on the unmet need in the with the retrospective analysis of the data, which we kept it after having defining those patients where we wanted to use this concept. This is what as criteria which I showed you. This was again, I say that we developed it initially, and then subsequently we took this work to see how the treatment effects has the treatment has an impact in the outcome. But what this work did for us to give the hint that yes, in this larger tumor, in the bigger tumor in oral cavity cancer, which would have gone for palliative treatment otherwise, you can make a proportion of patient resectable, and out of those patients who can get operated, almost half of them can be long-term survivor. But that also led to many more questions, which is an important part of the research. That if you want to develop a concept, you want to develop the concept and expect the people to agree to part of it, then you need to answer many more questions. And these are the questions which came up once we started discussing this concept and the outcome of what we had done. The questions were, what happens to different T4 patients? Is the T4A, T4B having a similar impact? What happens to the compliance? Because usually we do surgery upfront, you are giving some other therapy. Is it compromising the subsequent treatment? The next question was, what is the complication after surgery if you have given chemotherapy before surgery? Because that is what not routinely done in oral cavity cancer. Another important question for this concept was, what is the margin? Because you are doing surgery after chemotherapy, so tumor size becomes less. How you're going to operate, and what is the margin you're going to take for this tumor to see that your margin positivity rate is different as compared to if you do surgery upfront. And what happens to the elderly population? Because almost the median age of the patient of head and neck cancer is around 55, 60. So you have a good number of people who is elderly, and again, giving a systemic therapy in a population where you usually don't give it. So again, we did some work in this area. Again, I repeat, this was unmet need, again done from the data which was kept and was retrospective. And you can see the first one, that paper in JGO was regarding the compliance with the new adjuvant chemotherapy in this setting, trying to see that are we able to find out any factor which can identify where we can have a poor compliance and we can intervene. One of our surgical colleagues did post-operative complications to compare in T4 tumor, which they have done upfront surgery, versus in T4 tumor, where they had done given chemotherapy and then followed by surgery to see that was the complication rate similar. And it appeared that yes, they were similar, they were not different, reassuring that when we are using this approach, we are not increasing the complication of the surgery in these patients when they undergo surgery. There was an important aspect that what happens to the T4 tumor separately. And it appeared in T4B tumor also, it appears that similar benefit is there, what we have seen in the whole group of patients. This was again regarding margin. This was again the work done by one of our surgical oncology colleague who did a match pair analysis to see that the T4 tumor, which they have done surgery upfront, which they thought resectable, and they compared with these patients where we had given chemotherapy, then followed by surgery, where the revised margin was taken. And what we can see here that margin positivity rate was similar in both these group of patients. Again, reassuring that in this concept, your margin positivity rate doesn't go up if you are giving them chemotherapy and then followed by surgery in these patients. We also analyzed the data regarding, which got published in Head and Neck Journal, that what happens to these geriatric patients. So yes, it appears that if you select them properly, you are able to deliver this treatment. And these were some of the work in this area. Now, important question remains, if we did this work, were we able to impact, and was there some acceptability for this concept? Yes, this is the National Cancer Grid guideline with some around 200 odd members. And what you can see here, that in borderline resectable patient, NACT, and if you see the highlight, which group of patients were there, they were similar, which we had mentioned in our paper, and that's the reference for it, especially in an unmet need population, which is fairly common in our population. Not only that, this is a Indian Cancer Clinical Practice Consensus Guideline, which has adopted the same publication to see that this concept works, and you can have a group of patients where you can potentially give curative treatment. In fact, ICMR guideline also mentions our publication to put forward that in T4B tumor, one can consider this approach to convert some patients who are relatively unresectable upfront to resectable patient to hopefully cure some of those patients. What it highlights for me, that if you do have a concept, then many times your retrospective data in your clinical situation, again I repeat, for me this is our clinical situation where we wanted a solution and which was unmet need. We don't have a, I'll say, extraordinary solution, but yes, a good number of patients, they benefit. We also extrapolated this concept in many situations, and I'll highlight one of them. And as I said, I showed you our shortcomings in initial two concepts where we failed. I'll keep showing you successes because we can't keep telling you all our failures. So what we did was we extrapolated this concept at other places, and this was our paper for locally advanced and borderline resectable esthesioneuroblastoma and sinonasal tumor. Again, a retrospective analysis of our data because we did work in a similar way. And what you can see here, the NCCN has quoted this as one of the way to do work in this area and one of the way to treat in this area. And the reference is the same paper which was there. Again, highlighting that if there is an unmet need, and if you can work on that with as a retrospective analysis also, then, and it can, if it is structured, then it has a merit and it gives you a solution in the clinic. Now we know that we are from developing country. We have a good number of people who can't afford costly treatment. Many of them can't afford those what we call not so costly treatment also. So we had a challenge, especially in head and neck cancer patients, developing affordable systemic therapy in patients who are advanced disease or recurrent disease where you don't have any other treatment apart from systemic therapy, to see that can we improve outcome. Now, do we have a treatment available in this situation in NCCN or worldwide or not? Yes, we do have it. We have a treatment called Cetuximab based treatment. We have a drug which works in this setting and it improves the survival by 3 months. We do have a immunotherapy in this setting now, and immunotherapy works fairly well. But when we analyze our data, we realize that only 1 to 2% of our patients can afford it. And that was a challenge for us, that if we need to work in this area to see can we develop treatment for our patients which has a proof that it works and it is cost effective in this setting. So what we did initially, we tried to develop drugs which is cheaper. We tried to choose them, and we tried to develop a concept which is not our concept. We call metronomic chemotherapy. Dr. SD Banavali, he is our academic director. He works a lot in this area. So we borrowed the concept from him, and he uses this concept a lot in a peripheral cancer center which he helps running, and he did assure us that it works, and he has seen it that it works. This is the concept of metronomic chemotherapy. You give in 1/3 to 1/10 of the doses, you give more frequently, and it appears it has a lesser toxicity and may be more efficacy. I am not saying I'm vouch for it, but this was the concept which was there. What attracted for us was that we were sure that cost is far less, and then we wanted to know it works or not. As we didn't have any good treatment initially, we tried to see first with a retrospective analysis for the patients who had received this drug in the clinic and see that does it work. Initial publication of around 18 patients, and next publication we had of around 70 patients. Both retrospective data, what it assured us, it is not a miracle drug, but it does work in the clinic. It does work in some proportion of patients in the clinic. Now that pushed us to develop this concept, and subsequently we took this concept and we did have this phase 2 randomized trial. After retrospective study, we knew that we need to see that does this drug work, because we do have another drug which is there in the clinic, and to see that how it is advantageous as compared to the other chemotherapy, Cetuximab and immunotherapy, as we can't afford, so we have not taken in the standard arm. And here we compared this oral tablet, that is methotrexate and celecoxib, to IV chemotherapy in a phase 2 study. And it appeared in this phase 2 study that this oral tablet, it works better than IV chemotherapy, that is cisplatin here, as far as the progression-free survival is concerned. That was the primary endpoint, and also a hint that maybe overall survival may be better. In fact, I'm not showing you data for quality of life analysis. It also was better for oral tablet. Again, not a dramatic drug, but enough to keep us involved in this concept. So subsequently, this phase 2 study led us to develop a phase 3 randomized trial, which we did, and we compared the oral chemotherapy to IV chemotherapy in this setting. This was around 400 plus patients randomized trial, and what it showed that this oral tablet is better than IV chemotherapy, and also as far as overall survival is concerned, and also the quality of life is better as compared to patients receiving IV chemotherapy. And what it does for us, it does provide an alternative to cetuximab and immunotherapy, which 95 to 98% of our patients can't take it. For them, an option in the clinic, so that can be used as a routine treatment for these patients. While doing, we also realized that as this drug is marginally better, it is safer, it doesn't give some dramatic result. So we need to work hard to see that can we improve beyond this, because median survival remained around 8-9 months, which is better than what you get without any treatment or some IV chemotherapy. But again, I repeat, it was not dramatically different, and the huge unmet need remained. But this was a small question which was answered. But subsequently, what we did was we took a concept that can we improve upon these oral tablets? Can we add this something to it and then see that does that concept becomes a bit better than what we have been doing till now? So what we did, this oral tablets, we were using 2 of them. We added a third one. So what you saw earlier was methotrexate, celecoxib, where methotrexate was given weekly, celecoxib daily. We added a drug called erlotinib because we had in between tried to analyze what is there in the literature for the different drugs and trying to find out which we can combine. We realized that there was some decent data regarding erlotinib alone working in this setting. And this was a phase 1/phase 2 study to find out the dose and then subsequently to confirm that this drug works. So we first found out the dose in the phase 1 component, and we came to rather than 15 milligram or 9 milligram per meter square of methotrexate. And this combination in phase 2 showed a response rate of around 40%, which is fairly encouraging in this group of patients, because these are what we call platinum refractory patient. The chances of they having a response in the otherwise the usual treatment is going to be around 10% to 12% odd, which was encouraging. And also the progression-free survival and overall survival was also encouraging in this setting. Now, again, for us, important question remains, how does it impact in the clinic for us? And or did it impact in the clinic? This is, the National Cancer Grid guideline, and what you can see that, metronomic chemotherapy is one of the options which has been agreed upon, as one of the treatment options by National Cancer Grid guideline. And for that triple metronomic chemotherapy, if you see this up to date, which is followed fairly well, the triple metronomic chemotherapy has been referenced and has been talked about. They are not saying this is one of the standard treatment, but has been referenced and talked about, suggesting that yes, these are some of the options, at least definitely in a country like ours, where one can use these treatment to give to our patients, especially in the setting where they can't afford the immunotherapy and targeted therapy in these patients. We also were working on, when we were discussing in our clinic for all the questions we had, then we do realize that many of those treatment which we used to give, the different people had a different approach of giving those treatment. And we used to wonder always that is one treatment better than worse? We used to conclude they are similar, but none of us used to be sure about it. And what it did, it led to us to develop comparative study which can provide some meaningful solutions. And one of them was that in head and neck cancer, in locally advanced tumor, we give radiotherapy and cisplatin. The question has always been that is giving cisplatin every week good enough as compared to giving cisplatin every 3 weeks? This is the reasoning why we did this. We know that data is very good for 3 weekly cisplatin in this setting, but 3 weekly cisplatin has an issue, because in adjuvant setting, almost 80% patient has a grade 3 and beyond toxicity, and globally also 50% plus patient, they are not able to take the third dose. And there is some concept that maybe cumulative dose is more important than giving those which schedule we use. And weekly cisplatin is widely used in spite of data being there maximum for 3 weekly cisplatin in this setting. And there were many retrospective study, prospective trial, one-off, and guidelines used to mention as this as an option. in spite of having a very limited data. And that is what we led to, that there is no level 1 evidence in this setting. Can we develop this? And that led us to this study, where we compared weekly cisplatin to 3-weekly cisplatin in locally advanced head and neck cancer. And what we found, that if we give 30 milligram, that was the dose weekly given, as compared to 3-weekly, local control was not as good as 3-weekly. And that led to this. Again, if you can see, this is an NCCN guideline, that this is referenced as a discussion for weekly versus 3-weekly cisplatin in this setting. There is another trial also, but this is also one of the trial which has been discussed in NCCN. If you take up-to-date guideline, again, it does reference this paper as a reference for use of weekly cisplatin versus 3-weekly cisplatin in this setting, highlighting that many times comparative study gives us some meaningful solution, especially in the clinic, when we are not aware that if we treat one group of patients with more than one way, can one way we know is better or worse than other. As we realize that in spite of data being there for 3-weekly cisplatin being more and more people uses weekly cisplatin because they are comfortable with. So we had in our mind, can we make it better beyond this weekly cisplatin, especially in our setting? So we were looking for some drugs, and as a drug is tough to come by, especially in head and neck cancer, we had a drug which is there in India, which is a relatively generic version of Cetuximab, and relatively less costly. And with all the discussion from head and neck DMG group, we were able to convince the people, with the drug manufacturer, to support this drug development in this setting, in spite of drug being in the market for same indication. And they did, as an investigator-initiated study, they supported with this drug for comparing in head and neck cancer in locally advanced setting, that is a bigger tumor, giving radiotherapy plus cisplatin, and comparing with it radiotherapy plus cisplatin and plus this EGFR inhibitor. This was the trial design. 536 patients we had randomized, and what we found, that for many of those, one primary endpoint, that is PFS, and the secondary endpoint, what we call DFS and local regional control, it was better, but not for overall survival. So again, some solution in this setting with something which is available in our country, in this setting where we were not able to move beyond cisplatin. Now, we also learned while doing another issue, when we develop a question, that lab is very important. And we know that globally, but we also learned in a hard way. And I'll give you an example. And also we learned, always remember, apart from science part of it, don't jump the line. See that every aspect is there when you want to develop a question. And how did we learn this? In lung cancer, many of you will be aware that a good number of patients, they have EGFR mutation. And in EGFR mutation, the targeted therapy works better. So when the first publication came, that is the time when we brainstormed in our group, and we thought there needs to be a study from India. We did write the study. We went through our DMG department and ethics committee, all done. And then we realized we don't do this test in our country frequently. We don't do this test in the TMH. So we realized this trial will not move forward. If we don't do this test, this trial requires the test. That is the basis for this trial moving forward. So this trial was not moving forward because this test was not done at TMH. And that taught us, don't jump the line. But what we did, that we subsequently wrote a new project to develop this test in Indian context. And because there was no, at that time, there was no kit also marketed. So fortunately, we had a good collaborator, Dr. Ruta Mulerkar and Dr. Amit Dutt at ACTRAC. And we also got a summer trainee who helps us developing this test in our lab. And we could develop a test which was not so costly. So almost everyone could get this test done at a TMH. This also led to understand for us what is our EGFR mutation rate in our population. That gives us a more feasibility of understanding that the project we had written for randomized trial is feasible or not. So it showed us that it is feasible. It also helped us understand what kind of pattern of EGFR mutations we had in different population in our country. And yes, because we developed the test and the test was easily available, we also could complete that trial. So this time the story was not as bad as I showed you for letrozole, because subsequently with the hard work of many other people, we could complete the study, which showed that yes, in EGFR mutation positive patient, targeted therapy is better than chemotherapy. When we were doing this study, we also realized that as much we want to show this as a good example of how targeted therapy works, we also understood that ultimately this treatment controls the disease for around 9 to 10 months, which should be around 4 to 5 months early. So it's good. But then we need to work better on this. We did have other drugs which was coming in the horizon. And I'll show you, this is a drug called osimertinib, which is good, excellent. But again, only 1 to 2% of our patients can take it. That led us to develop some treatment in this situation to see that we are able to develop a treatment for our patients, if not same, at least a similar outcome. We were looking for many options, and we did realize there was a lab data and a small phase 2 data, which was there in abstract, suggesting that targeted therapy in this setting with chemotherapy may have a synergistic effect. And phase 2 data was promising. And that led us to do this phase 3 randomized trial of comparing in a lung cancer advanced stage disease targeted therapy like gefitinib and combining targeted therapy plus chemotherapy. This was the outcome. It did improve the control of disease, which was comparable to what we can achieve with a newer drug like osimertinib. And also it did improve overall survival in this setting. For me, what was more important, that I'll show you more important part, but some accolades what we got for this work. We had an oral presentation by Dr. Vanita. We did have, it was in top 30 abstracts in ASCO, and also it is referenced in, up to date. It is referenced in the guidelines like, ESMO guideline as one of the treatment option in this setting. And also it was on the Nature Reviews Clinical Oncology, as a commentary on this. So some accolades for this, But for me, more important was, at this moment, you have almost 8 treatment options in this setting. Out of those 8 treatment options, the last 5 is better than the first 3. But out of the last 5, if you see by the cost, except this combination, that is TKI plus chemotherapy, most of the treatment can't be afforded by most of our patients. So if I took the number, maybe 5%, maybe 10% of our patient can take it, but this treatment can be taken by almost all patients, and it can be provided by almost any government scheme which is available to us in this setting. We do concede that the osimertinib, what is showing here, the tablet may be safer, but if my 95 or 98% of our patients can't take it, then we need to have an alternative which is a bit toxic. I do concede chemotherapy plus TKI here is a bit more toxic, but having a similar outcome in these group of patients. So this was to develop a cost-effective treatment in this setting in collaboration with lab to improve outcome of our patients. What it led us, I can take the questions on this subsequently, because we also realized when you do one work, it gives flip to many other works which comes along. And this was a work done in collaboration with Dr. Amit Dutt. where we wanted to know, we wanted to develop tests, we wanted to develop panels to see in especially lung cancer that how our mutations are there, which kind of panel we want to develop. So the initial work of working together led to knowing what kind of mutation profiling you have in our population. And this was the work by Dr. In the collaboration with Dr. Amit Dutt. And subsequently, this led to development of an NGS panel, in this setting because of this data being available. So many times, one work or two work that leads to third, fourth, and fifth work in this setting, which I can give for the example. If the question comes up, I have not put it here. This was just an example to see that that working together, working on a question, working on two questions can lead to having answering or developing many more questions subsequently. We do have again our problem of which we had in a relatively big way in our clinic. We get a good number of patients who are not in a good shape, and that is relatively common in Indian population. And these are two work which we try to develop, the chemotherapy, role of chemotherapy, where the patients comes in the poor performance status. This is the first small cell, and showing that yes, you can salvage some good number of patients. And this is for non-small cell lung cancer, again highlighting that one can salvage some of these patients. And these are to highlight that these are our local problems which we see in the clinic, and then seeing these in clinic, these problems, we need to keep thinking how we can provide solutions with whatever is existing there in our in our clinic, and also with the resources available in our country. This is another example of repurposing of the drug, aprepitant, which is used for nausea and vomiting. We do realize that there is a mechanism where it works on the cough. And this led to our randomized trial to comparing aprepitant in this setting where they have failed with other and other cough measurement, other cough measures, anti-cough measures. And it appears it has some merit to it, that if you do have, this was in lung cancer patients, a cough which is not responding to other treatment, one can consider this drug as one of the options. This also taught us many other things. Sure, we'll be happy to discuss that how we need to do these kind of concepts, because for supportive care, these were our initial studies, how to have a placebo there, which we didn't have. And then we realized how things are important when we do these kind of a study. But yes, a decent solution in this setting. So for me to conclude, developing research question is one of the important aspects of the research. It is important for question to add a value in some aspect beyond what we know today. It should be any small aspect. That's what I have realized, that you can only answer a one little question. You can't answer with a trial the whole solution for the humanity. So we need to see that, are we able to add a small little value beyond what is there today? And if it is excellent. It's a small little value what we can add. It is important to be careful in scientific aspect of the research question development. Absolutely no doubt about that. That science should be fairly robust. But we also realized while doing this, it is equally important to ensure that research question is also developed considering the resource available. So we can think about moonshot. I know that we can keep thinking, but I don't think so in India. I'm looking forward for in a near future ever a moonshot coming here. But sure, I know for a fact that yes, we can do a good ground shot, and ground shot can be done by many of us. And ground shot can do, or ground shot work can give many good solutions to our people who can benefit from the work here. My acknowledgements, there is a long list. This is all the people who work in the lab and the residents, which they have been very kind. They listen to me and they work on this area. They many times they work late night, but they do. my coordinators who work very hard, and many times patients, they identify with them far more than us, but working very hard here. My very close collaborators, as I say, collaboration we do with many people, Dr. Amit Dutt from the lab side, Dr. Vijay Patil, Dr. Amit Joshi, Dr. Vanita Narona, Dr. Nandini Menon, Dr. Anuradha Chowgle, and Dr. Pratik Chandrani. So, these are people who eat each other's brain a lot, and try to see that we develop some meaningful question, and it may be not again repeat moonshot, but yes, a decent ground shot. This is the people from the lab who works together to help us in answering question. And if you see here, all females, maybe they have taken up Beti Bachao, Beti Padhao from our Prime Minister seriously. But yes, they have been very helpful. Three people whom I definitely want to acknowledge: Dr. Babsi, my teacher at Kidbai, very encouraging. And two more people, Dr. S.D. Banabli, my ex-HOD, now my academic director, always encouraging, and always seeing that when you are in hot water, especially in India, if you do studies, you can be in hot water many times, so that you are not in hot water always. So you are able to do some work also in between. And Dr. R.A. Vadbe, his director TMC, again, very always encouraging, and always willing to be there if you are in hot water. So my acknowledgement for them. These are many people whom I work with, which is there, and my family. Thank you so much.